Good morning, everyone. Thank you to those who are able to join us in person for the conference this year. We are excited to welcome you to the state of Arizona and want to take a moment to recognize the place in which we are holding this conference. On behalf of the National Coalition of STD Directors, we recognize the 22 tribes that have inhabited the lands of Arizona since time immemorial. This occasion is hosted in the Salt River Valley on the ancestral territories of the Acamel-O'odham, Tohono-O'odham, Pipash, and Yavapai Indian communities, whose care and keeping of these lands allow us to be here today. The National Coalition of STD Directors acknowledges and supports the sovereignty of these nations as we seek to foster a healthy and thriving environment for all tribal governments and their citizens. We believe in incorporating Indigenous knowledge systems and research methodologies as we collaborate with Indigenous communities to foster an environment that is resilient to emerging and changing public health needs. Today, we are gathered to commemorate the resilience that has brought us to this moment. Many of our colleagues could not be here with us in person today, and we really struggled with the decision to hold Engage this year, knowing the incredible challenges that our field is facing. But it is because of these challenges that we have persevered. We are united in protecting the health of our communities, and we believe that the moments that we have together to reflect on past successes and present issues will be critical in preparing us to meet the challenges ahead. In Arizona, we have seen syphilis and congenital syphilis rise exponentially over the last 7 years. Given these infections are subtle, often persist without noticeable symptoms, and have very long infectious periods, testing and treatment are some of the most powerful tools that we have to prevent transmission and keep folks healthy. Yet many of the people we serve do not have access to routine health care, let alone prenatal care, which is why the work that we do is so important. And now we are starting to see an increase of new HIV infections, while our resources to combat these infections are changing. At times, the work that we do can feel daunting. But we spent about 8 hours in pre-conference meetings yesterday, and I left inspired, because we are a field that is brilliant and passionate and caring and highly skilled, and we can solve this. A big reason why I started to get involved with NCSD is to learn from experts in the field so that I could better serve my community. Later in this session, you will get to hear about a few of the projects that our NCSD staff and committees have been doing to support programs across the nation. I hope you take full advantage of the time that we have together at this conference. I want to hear what you're doing, where you're experiencing challenges, and how NCSD can support you. We have a ton of work to do to combat rising STIs, but we are stronger together, and it is going to take all of us to rise to the challenges ahead. Thank you for your service, and I look forward to connecting with each of you over the next few days.
Good morning, and welcome to STI Engage 2025.
Welcome back to NCSD Engage from the great state of Alabama. I am so proud to see so many passionate faces here with us in beautiful Phoenix.
Yes, hello and welcome to the also great state of Michigan, or from the great state of Michigan. And yes, Anthony, it really is great to all be together as we face these unprecedented times. Being around so many brilliant people will give us all renewed strength and energy.
None of us could have predicted the place we are in today. That said, we have always been a scrappy group that gets things done, whatever it takes. Things might look a bit different in the months and years to come, but one thing that is certain, we will rise to these challenges and continue our important work.
Very well said, Anthony. Yes. This year's theme, New Frontiers in the STI Response, is quite powerful and it's very true. We chose the theme to represent our new reality. We are all pivoting our efforts to ensure that we maintain core STI and HIV services in the communities that we serve. Because our partnerships are critical to this work, we could not be happier to be here with all of you as we share our ideas and our strategies and network with each other.
This week, we celebrate and reaffirm that sexual health is central to overall health, that public health is essential for the nation's health, and that we still need an equitable, sustainable, and systemic response to sexually transmitted infections.
I can't see. So we will spend this week taking stock of where we are and strategizing about future threats and future opportunities to support the sexual health and wellness of the communities we serve. Plus, we will make sure that you leave here with things you actually can implement at home when you get back. As we face substantial challenges today, we also know that there will be more to come in the fight to reduce STI infections across our country.
We are so proud to be surrounded by friends and colleagues from a wide range of professions, program managers, DIS, epidemiologists, clinicians, therapeutics, and more, who have gathered to share knowledge and expertise.
We are also sending lots of love to our friends and colleagues across the country who could not come. The fact that they are not here doesn't mean that they are any less part of our successes, and we know that they will be with us as we all work together to keep our field, strong and our nation healthy.
At this time, we want to welcome to the stage our fellow planning committee members. They have put a countless hours organizing this event.
And also, I think they might be elsewhere, but Elizabeth Finley and Stephanie White, special thank you to you both. You have kept the planning committee on track as you managed other important work to support our membership. And I also want to thank the entire NCSD staff. It took a whole team to make sure we got this conference together and on board.
I want to thank our conference sponsors. Because of your generous support, we were able to make this conference a reality.
Yes. And finally, NCSD board members, I want to thank you all for your insights, your camaraderie as this conference took shape. I'd like to have a special shout out for Becca, our board chair.
Woohoo!
Woohoo! Frankly, for just being Becca, we all know her and we love her. I have to say she's no longer a co-chair, but she may as well have been. Your leadership through this process was really amazing, and we thank you for your leadership and support. Thank you.
We have a ton of fantastic content planned for this week. In addition to welcoming you all, we also have the honor of introducing David Harvey, the Executive Director of NCSD, to officially launch this conference. David has been a tireless advocate for our sector since he joined us in 2016. His role has certainly evolved in the recent months as we're all literally fighting for every dollar we need to do his work.
Please join us in welcoming David to the stage.
Come on, David.
Come on.
Good morning, STI Engagers. We could do better than that. Good morning, STI Engagers. Good morning. Everyone awake? There is one message I want you to take away from this short talk that I'm giving this morning. We will survive. We will overcome. Yeah, you can applause. Before I get into a little bit of what I want to talk to you about this morning, I want to introduce the conference just a little bit to you. I don't have to tell you that this has been a great moment of uncertainty. And you'll see the uncertainty play out in our meeting because we weren't even sure we could hold STI Engage this year. And yet here we are. If there's one thing that our field has proven, we are scrappy, we are fighters, we do whatever it takes to win with whatever limited resources we have. And here you are, beautiful people. So thank you for coming to Phoenix. I know it wasn't easy. This is a moment of funding cutbacks, layoffs. So coming to this meeting is a big deal. We know it. And this is a very, very important moment for us to take stock of where we are to arm ourselves to go forward. So, another introduction. How many of you here today are first-time STI engagers? Wow. Thank you for being here. How many people in this audience are DIS? Oh. And how many people are STI directors? Loosely defined. You oversee your programs. All right. Welcome. And all the rest of you, welcome. Now, I want you all to stand up for a second, those of you who can. And feel comfortable doing so. Stand up. I want you to, in 10 seconds, introduce yourself to someone standing next to you that you don't know. Okay. All righty. Okay, this is always a dangerous move. All right now. There is a reason we do this. And now is more important than ever. The people you just introduced yourselves to are new relationships. They are people that can sustain you, nurture you, help you through the bad times and the good times. That is one of the goals of STI Engage, to build a network, a movement, a set of relationships that are going to help build our movement, because we are a movement. So I'm glad you had a chance to introduce yourselves. I want to meet every single one of you. So welcome to Phoenix. Once again, we are going to survive, we are going to thrive, and we will ultimately build back an even better public health system. I think now I can sit down, and I've probably said enough. No. I got a few more things to say. You would expect that, I would think, from me. My pointer. Yes. So, I have very limited time with you this morning, but this is a very important moment, I think, to take stock of what is going on, where we've come from, and hopefully a few tidbits of insight into where we are going. And above all else, I want you to understand what NCSD has been doing for the past 3 months, because frankly, we've been working our asses off, just like all of you in this room. And we are going to prevail because of these efforts. Today, we have a really special PriorityONE Live Briefing to you that we're going to be doing from the stage. And I've just been told that we have over 500 people that are logging onto the Zoom to listen in to today's PriorityONE briefing. So I'm thrilled. And I'm going to talk to you a little bit more about why we did this initiative and how it's going. So, I'm going to cover a little bit of some history that you may or may not know. I'm going to share a little bit about our experiences, the HIV and STI community, and all with the theme of past is prologue. Understanding a little bit of where we've come from helps us understand where we are going. Past is prologue is a very famous carved statement on the Museum of American History in Washington, D.C., on the outside of the building. And when you go to Washington, the next time you go to Washington, make sure you look for that. It seems very appropriate to this moment. Past is prologue. We have some insights to learn from our past that are going to help us go forward. So, I have a couple of limitations to note. These are my subjective viewpoints. Not everybody will agree. I'm old. I've been around a long time. I was around when the Ryan-White Care Act passed. I actually worked on it in Congress. I was around when the Americans with Disabilities Act passed. That was the year 1990. And so I have witnessed a lot, seen a lot of change. So I'm going to bring some of that experience into this room. But it's not going to be complete because my time is so limited with you this morning. We have seen an enormous focus right now on the Centers for Disease Control and Prevention. It is the subject, it is the whipping boy or girl, whipping people of the federal government, the agency that is taking enormous criticism, some of it focused on the COVID response. And so taking stock of some of that helps us understand what's going on with the changes that are being called for by this administration. And again, the theme is taking stock of the current developments, the immediate past, in order to understand where we're going. So, the first thing that I want to talk just a little bit about in terms of history, recent history, is you all may have heard of the infamous policy document called Project 2025. And for those of you who have not perused this 850-page report, yes, 850 pages, it is a bit of the playbook that has been out there for a couple of years about what would happen in a new administration. What were the policy priorities? This was not a secret. We knew a lot about what campaign pledges had been made and where the Trump administration might go if they were elected to office. The lead author of that document is someone by the name of Russell Vought, who is now the director of the Office of Management and Budget. And for those of you who are new to that acronym OMB, these are the people who make all the funding decisions. And what we have seen in this administration is a concentration of power in that office. Mr. Vought is a very important figure in this administration, and he is approving grants and all kinds of other policy decisions. So for those of you from health departments, community-based organizations who have experienced delays in drawing down your grants, some of that is focused and concentrated within the Office of Management and Budget. These points that are below on this slide are all things that have already played out. Eliminating the Department of Education, deporting undocumented immigrants, reducing the federal workforce, revamping the public health agencies, and requiring work for some on public assistance. These are all things that are in play at the moment as we speak. Now I'm going to shift just to a little bit This is in no way a complete overview of the history of CDC. So for some of our CDC friends and colleagues who are here with us today, I make no claim that this is a complete overview. But the reason I'm touching upon this again is a little bit along the theme of past is prologue. These are some major noteworthy items in the timeline of the development of the Centers for Disease Control and Prevention based in Atlanta, Georgia, part of the federal government, part of the Federal Department of Health and Human Services. CDC has gone through a lot of changes and growth over the years. 1940s started as an agency that was really focused on malaria control in the context of the world wars. As you can see, the agency gradually expanded right up to the 70s and 90s when the word prevention was added to the CDC. And why is that significant? Because that word prevention has been a target of this administration in terms of wanting to take the agency back to some of its roots as they define it. That is an important thought to understand about why there is the discussions taking place that are right now, which is a desire to focus on core infectious disease functions, that somehow the CDC went wrong on COVID response. I'm not commenting on other federal agencies because they play obviously major roles too, but I'm just talking about CDC right now from a historical point. But COVID has been the focus of a lot of unhappiness of many people in the country. I don't have to tell all of you that. You lived that. You lived through those years. You were on the front end of that. Many of you were doing contact tracing for COVID. We all know how that went with the challenges and the wins with that. But this is a major focus of people right now in Washington, and that is why we're seeing a massive debate play out and a huge focus on changes of the CDC. Most of us have spent our lives working in public health and working with colleagues at CDC and receiving funding from CDC. This is all being upended at the moment. So now I'm going to shift just a little bit to a discussion around major touch points in the HIV and STI movement. And there's really some important differences to take stock of, which again inform our current lens and our current work. I don't have to tell you that the HIV/AIDS movement is the most successful health advocacy movement in American history. But a lot has changed in HIV as the disease has changed and become a chronic disease, as treatments have evolved. On the flip side of that, maybe not the flip side, but the STI movement has had a very different history. The STI field has focused on evolving the role of DIS, of trying to bring inadequate resources to bear to control an out-of-control STI epidemic. When I first started in this field 9 years ago, I met the legendary, infamous Dr. Gail Boland. And if Dr. Boland was here right now, I'd give her a huge hug. I love her. But she taught me very early on, I think, about the value of debate. I met Dr. Boland and listened to her talk at me for about 90 minutes. And I knew from that moment, whoa, we were going to have some robust debates. And ever since then, NCSD has worked with all of you to elevate the voice of the field to contribute to the formation of a new path forward to confront STI and confront the STI epidemics in America. It's not as though we've done so well at controlling STIs. We don't have a lot of money. And then you compare that to the HIV response, and it's really very, very different. So our era within STIs is defined by an era of looking at systemic reform and change, debate, and trying to win new resources. And we have a lot to take stock of in that area. When you debate with folks, when you debate with powerful folks, when you engage in systemic reform, not everyone likes it. I have a lot of enemies, you know. There are people in Washington who really don't like me. But as the old saying goes, if you're not shaking things up in Washington, you're not doing your job. So debate is a good thing. Systemic change is a good thing. And we are in the midst of a most profound moment of systemic change than we probably have ever experienced in our lifetime. So this is a couple of notes just to understand around the timeline and some factors that went into how the HIV response developed in this country from the 80s to the 2020s and the STI response. I started working on HIV when I was in graduate school in 1987, a long time ago. I told you I was old. And you can see here some of the notes around how resources were allocated. And for those of you who remember last year's session that highlighted the past directors of DSTDP, Dr. Judy Wasserheit was one of the people who spoke. In the early 90s, Dr. Wasserheit was the head of DSTDP and funded a series of clinical trials overseas. And her theory and hypothesis was, we can prevent HIV by first controlling STIs. There was very mixed results from those trials. And those trials happened at a very key moment when the HIV movement was really gaining steam. The STI community basically lost its role in solely taking on HIV from that era forward due to a number of factors: limited resources, some of the fact that these clinical trials didn't, they had very mixed results, which Dr. Wasserheit can describe much better than I. And so the HIV response took over, winning new resources, creating new structures at CDC, and then the rest is history. And here's a brief timeline of noting key developments about when money was allocated, which I remember, and talk about debate and controversy. I remember very, very well when the Ryan White Care Act passed. On the front page of the Washington Post was this huge controversy. The bill passed late in the appropriations season, no money allocated for it. And there wasn't going to be money allocated for it. So some of the seminal HIV activists decided to cause a controversy and call for a % reduction in all health programs in order to fund the CARE Act. Well, that got everybody all stirred up. And somehow, they found the money for the Ryan White Care Act. A little bit of a lesson there. From then, you can know the rest is history. The Ending HIV Initiative, which I was honored to be a part of in the first Trump administration. The first STI Action Plan. The first Trump administration initiated that at our request. And we had a massive infusion of funding under COVID legislation to expand the DIS staff nationwide, only to have that money rescinded. We are no stranger to rescissions and funding cutbacks, which happened to us 2 to 3 years ago. I know I'm going to figure this out. Okay, here we go. So, a little bit of a touch point on some of the histories and factors that have driven us to where we are today. Now, we are in an environment, a vastly different environment, where we are being challenged in many different ways, but we are no strangers to being challenged, although this is a very unique time in American history. All of the normal processes of Washington have been upended. Congress has ceded power to the executive branch of government. The separation of powers between the courts, the executive branch and government, and the Congress is being tested like never before in American history. And all of you remember your civics lessons, the three separation of powers. Supposed to be equal powers, right? That is designed in the Constitution from the founding days of the modern day America. And this is all being tested and upended as we speak. And I contend, and have said this too many times to count, but moving us from a mindset of thinking a little bit about, they can't do that. That's not the normal process. That's not the way the system works. That's not what the Constitution calls for. They can't do that. Really, we have to change our mindset and ask a different question, which is, why wouldn't they? Why wouldn't they? And once you delve into the answer to that question, you start to develop a mindset of thinking about, gosh, if they do that, what's going to be our response? And from there, it's important to move into identifying where our opportunities lie. And that is a theme you're going to hear throughout STI Engage, New Frontiers, our conference theme this year. Where are the new opportunities that we have? Because there are new opportunities. It isn't all doom and gloom, although we are facing huge challenges. So yesterday at the NCSD member meeting, we posed, in this theme and in this vein, we posed the question to members, many of you sitting in this room, what would you have CDC do more of, and what would you have CDC do less of? Yes, it is possible to answer that question and have a role in defining our own destiny. And that is what our conference is going to be about. Acknowledging the losses that we are experiencing right now, but also taking stock of where the opportunities are going to lie in the future, because we will have them. In support of that, these are examples of strategy questions that we've been asking ourselves at NCSD. What defines a winning strategy? Why focus on a worst case scenario first? Well, if you can answer the question of what is the worst possible case scenario you can come up with, then you're preparing yourselves on how to go forward. How do we survive? Where are the opportunities? How does the public health system rebuild better into the future? These are some of the strategy questions that we've been asking ourselves. These are some of the strategy questions you need to ask yourselves and your programs at the local level. From there, it's not rocket science to get into various case scenarios. And these are some of the things that we have been trying to think through in response to things that are being forced on us. It was not our choice, it's not our community's choice, to change the existing system. But change is being forced on us. But one of the scenarios is, well, gosh, the status quo system survives, but we have funding cuts. What gets prioritized for services and surveillance? What happens if HIV prevention funding is actually eliminated from the CDC, which is the current threat? What happens to surveillance, and what happens to all the programs that are currently getting funded? There is no doubt that the states are going to be driving the response going forward. How do you prepare? How do state health departments prepare? State and local jurisdiction health departments prepare? And how do we prepare as a community? If block grants are coming to us, some of which has been proposed, what is the structure of that block grant? What are going to be some of the limitations, and where are some of the opportunities going to lie to do things differently? So, Very, very briefly, I'm going to tell you a little bit more about what NCSD has been doing for the past 3 months. I can tell you I've gained a few lines around my eyes and I've got big circles. I tried to put on a little makeup today to cover all that up. I'm just, you know, I think we're all tired. We're all tired in this room, which means you must take time to restock, rebuild, relax, rest. This is a fabulous place here in Phoenix, Arizona. I'm kind of blown away by it. The impossible happened. It rained. It rained here. It rained. I mean, think about it. So it is possible to make the impossible happen. So let me tell you a little bit about what we have been up to. So I am officially announcing right here today the Disease Intervention Center of Excellence. There's an acronym that goes along with this name, but I don't really want to use it because it sounds an awfully lot like a certain law enforcement division of the federal government. But we have been using this acronym DICE. I think we're going to banish it from our vocabulary. Sounds a lot like ice. DICE. Anyway, Disease Intervention Center of Excellence. This is our new logo. Very excited about it. This is our response to the elimination of DIS training resources at CDC. We're going to privatize a lot of this, and we're going to bring it in under NCSD and work with other national partners to provide the training and the tools that DIS need throughout the country. And it's already underway. Jen, my button doesn't work very well, just so you know that in the back of the room. For those of you who have not met Jen in our back booth, she is the person extraordinaire who runs all of this stuff. And you don't want to cross Jen. That's all I have to say. We have a robust online learning management system. These are some stats that show you what we're already doing. I'm talking about this because I want you to know these resources are now available here. You can access the NCSD Learning Center via our website, ncsddc.org. This is a little bit of what we are engaged in under the overall umbrella of the NCSD Learning Center, the LMS. You can see all the different kind of learning products that we either already have many resources available in, or we are developing materials for. All the way at the bottom, you see something called Frontline Essentials. And I am thrilled that here with us at this conference is the American Association, I'm going to butcher the name, the American Association of Schools of Public Health and the National Board of Public Health Examiners. These are folks who very generously have stepped up as the landscape has changed to be partnering with NCSD on making resources available to all of you. And for those of you who have followed the very long history of DIS certification, it's coming. It's coming after 12 years of work. So Frontline Essentials is going to be that effort to support DIS certification with the training and the resources that you need. These are examples of the DIS learning pathway that are available to you right now through the Center of Excellence. Yes, I see Dorothy. You can go sit over there now. Disease Intervention Center of Excellence. Priority One. We are about to have a PriorityONE Live Briefing. This has been our response, launched 2 months ago, 2.5 months ago, to helping all of you understand in real time what is happening. This is the QR code. If you haven't signed up for it, sign up for it right now by aiming your phone on that QR code. We do twice live briefings and send out daily updates. It's everything you need to know about what's going on. These are our partners and sponsors for PriorityONE, which we are thrilled about, and this list is growing. And I also want to specially thank the people who have made this conference possible also, who are also involved with PriorityONE: Diagnostics Direct, Bavarian Nordic, Hologic, Gilead, and Roche. A huge round of applause for our sponsors in terms of making this meeting possible. Thank you. In summary, learn from history, plan, develop scenarios, organize your community. No, you don't need more data. Use your existing data. Produce it in a very, very simple format to make your case. I know that's hard for very good public health people to hear. Engage with us, engage with national organizations. We are here to make this field stronger and to build out. And as I close out today's session, I also want to take a moment to honor federal workers. The federal workers who many of you know, who worked at CDC, who are technically on administrative leave at the moment, but are people who have dedicated their lives to supporting all of you and this field. And here representing people who are on administrative leave is Frank Strona from San Francisco. Many of you know Frank. Frank has been a longtime leader in our field. He has supported all kinds of national initiatives, too long to go on about, but one of the ones that NCSD has worked very closely on with Frank is the National Internet Partner Services Initiative, the Online Technology Build Program. Frank is on administrative leave. I am so happy you can be here today, Frank. Please come up and just say a couple of words. We're already running behind, so we're going to zip through this. But Frank is here to represent the 100 federal workers who have been put on administrative leave at the CDC. Frank.
David. Thanks, David. Thanks, NCSD. And thanks, all of you. For 68 years, we've had public health advisors working in health departments around the country. And this dedicated group of public health analysts, project officers, advisors, and disease interventionists have worked hand in hand with health departments to reach the communities that are toughest to reach. We are out. We're no longer in your health departments. We were pulled rather rapidly. We know that. But let me make clear, the work of DIRB, and that's what we were called, Disease Intervention and Response Branch, and the work that many of you do is not just a job. It's a calling. A commitment to the well-being of our neighbors, our families, and the most vulnerable among us. And the loss of experienced professionals from our ranks is a loss for every community we serve. Disease intervention is not a luxury. It's a necessity, especially in times of public health intervention. And we're all over the place. Just to name, I won't go through because I know we're running short, but for the last 13 years, I've been working with health departments to explain that Grindr is not a dance club. It's an application that you can use to reach populations that doesn't cost you anything. We've got folks in Texas, Deb Carr, working with the Black Women's HIV Initiative. We have several of our team, Ricardo, Ken, Fred, Jerry, Brandy, who worked to disrupt, along with Topeka, Kansas, syphilis outbreak. Those were just in 2024. But we also have locally Bree Anderson. I don't know if Bree is here today. And her work that she did during COVID. So while doing work to train hundreds of National Guards and health professionals on how to do this kind of field-based work, she still managed to find a woman who had just given birth, who had syphilis, and find the baby. This is how we worked in partnership with all of you. I'm honored to represent this team. It's been a big change for all of us. It will be a change for all of you, as I know it's happening locally as well. So while we will say farewell to our partners and our friends locally, we know you will continue to champion the values of public health, support one another, and strive for a future where our collective expertise is recognized and respected at every level. Don't give up.
On behalf of all of us, Frank, thank you for your service to this nation, and thank all of the many other federal workers who are on administrative leave and not performing their positions. We're going to start our Priority One briefing now. Thank you very much.
Okay. Pages moved around. Excuse me. Good morning, everyone. Or depending on where you are in the country, if you are joining us from our live Zoom call, it may be a good afternoon to you. Thank you for hanging on while we just started a little bit delayed. Our Priority One briefings are always live, but as you can tell, I literally just dropped something. Today is live. We are on a stage, we have a mic, I'm wearing real pants, so let's do this. All right, my name is Chris Zivelich. I use he, him, his pronouns, and I am the Senior Manager in State Policy and Training at NCSD. And I am also a part of the Priority One team that is bringing you and your colleagues across the public health sector the latest changes to federal and state policy, funding, and programs that directly impact your work. With Priority One, our goal has been to create a safe place for learning so that you can decide on the best course of action for your organization. And if this is your very first Priority One Live briefing, that's fun, first of all, and our goal is to help you get your bearings so you can navigate STI Engage and the trail ahead with confidence that you know what's going on. Today is going to be a little bit different for those who have joined our briefings in the past. Can we get a QR code, please? It was really fun to just manifest that. Rather than doing our Q&A through the Zoom Q&A box, we are going to actually take them through Slido. So I encourage you all right now to take out your phones, scan this code, and keep that Q&A box open throughout the duration of today's plenary, so that you can, as you think and formulate your thoughts, put questions into that app. We will then select questions and do a little bit of Q&A at the end of the briefing. Please note that the views, thoughts, and opinions expressed by speakers and participants in Priority One are solely that of the speaker. They do not necessarily reflect a formal position of Priority One or NCSD, and they are for informational purposes only and should never be interpreted as policy or legal advice. So with that, I'm going to turn the stage back over to our fearless leader at NCSD and our Priority One Live Briefing facilitator, David Harvey. Thank you.
You ready? I have to follow my instructions. Put my water down first. So, I am thrilled that we're able to do a Priority One Live briefing from the stage. And thank you all for joining us. Thank you to the over 500 people who have Zoomed in for today's briefing and are with us virtually from around the country. What many of you don't know, we're going to open the curtain just a little bit on Priority One briefings. They're done virtually, as you know, via the computer, and CSD does not have an office to save money. We work virtually from home. And so what you don't know is that from the waist up, I'm often dressed up, a jacket or shirt. What you don't know is that I'm mostly sitting in shorts, my underwear, no shoes. Today I'm a little more appropriately dressed. What I do is sit in front of the cameras, frantically getting ready, which the NCSD staff can attest to. I've got a notebook, I've got a run of show, I've got a set of questions which I mostly do not obey or read from, and then I have my iPhone opened to the Slack channel, because that is how we communicate with each other behind the scenes. And I hope I've opened the right Slack channel, NCST team. I am on what we refer to as the PriorityONE Briefing Coordination. So that's where I am, folks, and that's what I'm going to pay attention to during this briefing. So, I want to welcome to the stage people who you have gotten to know very, very well through our briefings. Betty Lou Taylor and Stephanie Arnold Pang. As you have heard me, introduce them many times on our live briefings, Betty Lou Taylor and Stephanie Arnold Pang are two very special people who work very hard and passionately on your behalf. Betty Lou Taylor, for 25 years, led the committee in the Senate that writes the health appropriations bills that provides all the funding to all of you. And Stephanie Arnold Pang, you have worked for NCSD for how long? 13 years?
14 years.
14 years. Our longest serving staff member who brings a tremendous amount of expertise, experience, and wisdom to our government relations work. You all could not be in better hands with these two people. So, I'm going to sit down, and we're going to start out with a couple of questions, as we normally do with our briefings. Can you all hear okay? You're all awake? You're with us? Gotcha. All right. So, Betty Lou.
Yes, David.
My gosh, give us an overview of what is going on in Washington lately and what is going to be the hot topics over the next couple of weeks.
Well, thank you very much, David. Let me just by saying Washington, D.C. is a mess. The firing over 2,000 federal workers, the plan to close the Department of Education, proposed cuts and restructuring in HHS, program delays, budgets that don't give you any particular details about what the administration wants to do. All of this is causing major chaos and uncertainty. The next 4 weeks will be interesting as the Senate begins debate on the reconciliation bill and the House begins marking up the appropriations bills. There's also a $9+ billion rescission that's supposed to be submitted today to the Congress. It contains clawing back money for the Corporation for Public Broadcasting, National Public Radio, Voice of America, and all those USAID programs. And I also understand that this may not be the only rescission this year, that there may be several other rescissions coming down the pike. It could affect some of your programs. We just don't know right now. So over the next month, we'll learn more about the fate of the proposed Medicaid cuts in the reconciliation bill, as well as what the recommendations in the House and Senate are going to be on appropriations and funding for FY26. As you probably heard, there's a number of court rulings blocking some of the administration's policies, and at some point these rulings will come to a head, which could open the door for a constitutional crisis and separation of powers. Washington is now saying we need to do more with less. At this rate, we'll be diagnosing chlamydia with a mood ring and a consult with ChatGPT.
Betty Lou, we can always count on a little bit of humor from you. So together, we have been learning about all the arcane terminology of the legislative process, something that you have lived for 40 years?
Yes.
Longer.
I was a mere child when I started.
We have some folks who are here with us today who probably want to learn a little bit more and kind of do just a brief check-in on the process of reconciliation and the appropriations bills. These are terms, for those of you who have been in our briefings, know get thrown around all the time. The reconciliation bill and the appropriations bills. Can you just give the briefest of introductions and teasers to what these terms mean and how it works? By explaining, I guess, some of the key elements of the budget process.
Okay, you want me to do the reconciliation process first. The slide up is the federal budget process.
Oh, did I get the order wrong?
You did.
Okay.
So let's
In
regroup.
my briefing book, it has the question on this next. Oh, well.
Okay.
Hey,
so
this is what happens in real time,
so,
people,
so let's
when we're
talk
on the
about
videos.
let's talk about the federal budget process. So the slide up here. So let's begin with, there's two types of spending in the federal budget process. There's mandatory spending and there's discretionary spending. So mandatory spending is what we sometimes call entitlements. They aren't controlled by annual appropriations. They include Social Security, Medicare, Medicaid, unemployment, and food stamps. Mandatory spending accounts for about 2/3 of federal spending, and it's the primary reason that the budget is so high because the funds are provided to people no matter the funds are provided to people who qualify and are eligible. The reconciliation bill controls mandatory spending, and it provides funding over 10 years. Discretionary spending is on the appropriation side. Discretionary spending is provided for only 1 year at a time, and public health programs like STDs, HIV, NIH, and HRSA, those are all controlled by the appropriations process. The rest of the budget is interest, and that's interest on the federal debt, and that's the 13% you see on the chart.
Okay, oh, great. Okay, thank you for that overview. We have heard so much, this terminology really cracks me up. I think it's a PR term that was adopted, but we've heard so much about the big, beautiful bill, the big, beautiful reconciliation bill that just passed the House. Can you explain what that is and how it's tied to reconciliation?
So the reconciliation bill controls mandatory spending. It also includes adjustments to the debt ceiling. It has no effect on the discretionary budget. However, this bill does include increases for the Defense Department, and those will be counted on the mandatory side, so it wouldn't be in the ceiling for the discretionary spending. The total cost of this bill is $3.5 trillion and will add about $2.3 trillion to the budget deficit. There's also several provisions in this House-passed bill regarding Medicaid eligibility that could kick people off the rolls, and it will have a detrimental effect on public health, including HIV and STIs. There are also some administrative hurdles and fees for low-income individuals, which could delay access to health care and potentially lead to poorer health outcomes. I'm going to turn over to Stephanie, and she's going to talk about some of the Medicaid provisions in this reconciliation bill.
Yeah, thanks, Betty Lou. So a few of the provisions regarding specifically Medicaid in the House-passed bill that will remove at least 7.6 million individuals from the Medicaid rolls include work requirements. So for those both in the non-expansion part of Medicaid and the newly expansion section since the ACA passed, enrollment moving from instead of once a year, individuals will, if this would become law, enroll twice a year, so every 6 months. So more paperwork for those individuals, and there would be cost sharing for coverage of those in the expansion group as well. And all of these provisions increase the administrative burden that lead to barriers to people falling off the rolls of Medicaid. So it might not say we're going to cut this group or that group specifically, but have no misconceptions. The goals of these provisions, the math that Betty Lou just talked about, isn't going to work unless people are actually removed from the Medicaid roll. And that is the goal of removing people from Medicaid coverage of these provisions.
Thank you, Stephanie. So, Betty Lou, why is Congress using the reconciliation process to get this all done?
So the beauty of the reconciliation process is it only requires a simple majority to pass the House and only 51 votes to pass the Senate. Most of the time, bills in the Senate require 60 votes. However, in the Senate, there's some special rules for recon, which requires provisions in the bill to have a direct effect on the federal budget. This is the so-called Byrd Rule or Byrd Bath, named after the late Senator Robert Byrd of West Virginia. This rule limits what can be included in the Senate bill and ensures that the bill focuses only on budget-related items and it doesn't have political issues or vehicles for social change. For example, the House bill includes a provision that prohibits the use of federal Medicaid funds for gender transition for minors and adults, and it also prohibits federal funding for Planned Parenthood. So the Senate parliamentarian will have to rule on these provisions, but in my opinion, neither one of these would be permitted under the Senate rule because they don't have a direct budget effect. Getting this bill through the Senate won't be easy. Senate Majority Leader Thune can lose no more than 3 Republican votes because Democrats won't support the bill, and there's already 6 Republican senators that say they've got major issues with this bill. So some have balked at the spending cuts in the House bill, some want more spending cuts, some have problems about the Medicaid requirements, especially for the 80-hour work requirements for child care, mothers and others being kicked off the rolls. So politics is playing a major role because Republicans are against the president's proposal, and they're threatening some of these members who don't want to vote for the bill. They're actually threatening to run a primary candidate against them and fund those primary candidates against the incumbents. So once this bill passes the Senate, it's got to go back to the House. The House will have to pass it. Now, the last time the House bill passed this bill, it was by 1 vote. So Speaker Johnson's going to have a hard time if there's a lot of changes made by the Senate to get this bill past the House. So the goal of the Trump administration is to have this bill passed by the 4th of July. I think that's a lofty goal, but they're saying that they're going to make that.
Before I get into a final quick question for each of you, I think I want to ask something else. That is not scripted. Get ready. No. Why is all this happening? Why is this happening? Why is, in the most simple form, why is all this happening in the country right now? Can you answer that question, Stephanie Arnold-Pang?
Boy, $1 million, or maybe the, how many billions did you say the reconciliation bill was like?
3 to 5.
Yeah, so the
Trillion.
$3 to $5 trillion question?
What does this say about America right now, that all this is happening?
I think what this says, as I'm trying to be as nonpartisan as possible, I think that there is a redefinition going on, or attempting to be going on, about what the federal government's role is and who matters. And for those of us who work on the front lines of STD, HIV prevention, work with individuals who are barely working it together, working many jobs, and whose health might not be their first priority because they don't have housing, they don't have food, they don't know how to make ends meet for their families. Those aren't the people who are being prioritized by this administration, and they're not being prioritized for focus by the federal government. There is some talk and hope that the states will pick that up, but for those of you who work in state government, we know that state government budgets are very tight as well.
Because they are voices that have less power.
Yes, they have less power and less influence.
Betty Lou, is there anything you want to add to that?
I just think this is total control. I think this is, eventually, I'm afraid this is going to be a threat to our democracy.
Yeah.
This is raw, naked politics and power playing out, which we are all witnessing. So I think to round out this section of Priority One, Stephanie, what is going on right now with the FY25 appropriations and funding. Let me clarify for everybody. This is the funding for right now in the current fiscal year, which we all know is playing out. Never mind talking about next year's process, right? So what's going on right now?
Yeah, so right now we're in fiscal year 25. Don't worry, there will not be a quiz on when their fiscal years are happening. But right now we are in fiscal year 25. And if you can remember back a few months ago, Congress passed final appropriations for FY25 in March. And that law required the administration to put out 45 days later what's called a spend plan. And a spend plan outlines what the executive branch is intending to do with those congressionally appropriated funds, and that it is a legal requirement. And the Trump administration did meet the legal requirement. They did transmit a spend plan, though I might call it a spend plan, to Congress, but it was very thin. It was very little information. So typically we're used to seeing more information on getting additional details about how an administration, an executive branch, right? Remember our three branches of government. The executive branch headed by the president and the administration will spend out that money appropriated by the other branch of government, Congress. It's transparent, it can be tracked. Those of us who are advocates and work on this can talk to members of Congress and talk to the administration about how it's being outlined. But that is not really possible this year because the spend plan isn't public, and even members of Congress don't have a lot of information about what the president and the administration intends to do. So regarding right now, there are partial NOAs for STI programs that are funded by CDC have gone out. And HIV NOAs were supposed to be sent out on June 1st, it's June 3rd. And so at a minimum, the HIV NOAs are delayed, so we're in a little bit of a holding pattern regarding current, what's going to be funding right now for HIV and STI prevention.
Okay, thank you, Stephanie. And Betty Lou, shifting to next year, not the current year, next year. What's the proposal look like for FY26?
So as you can see from this chart, there's major cuts. So the budget for FY26 was transmitted last Friday. It includes cuts in a lot of public health programs. It proposes to cut $32 billion out of HHS programs, including CDC, NIH, FDA, HRSA, with plans to move many of those programs into the new Administration for a Healthy America. We're calling that AHA, or AHA. The budget proposes to continue the viral hepatitis, TB, and STI programs at the CDC, but they only fund them at $300 million in a block grant, which results in a $57 million cut below the funds that were provided last year. It proposes to fund the EHE program at approximately $550 million, and that's at last year's level. But moving all those to, and that and the Ryan White AIDS program, all that would be moved to AHA. So let me just emphasize that this is only budget proposals, and while the White House and the Congress are still all in Republican control, I suspect there will be major pushbacks even from Republicans for some of these proposed eliminations and programs like cutting NIH in half and moving some of these HHS programs to AHA. So keep in mind that this is a very long process before the final FY26 bills are enacted, and there's still factions in the Republican Party that want more cuts and deficit reductions, and that's more than the president requested. So we are in for a very long, drawn-out appropriations process before any of these proposals are enacted into law. I suspect, and this is just my opinion, come September 30th, that these bills will not be enacted into law. Congress will need to pass another continuing resolution, at least through December, but we could be under a continuing resolution for the entire fiscal year. But there could be some major changes, and we don't know what those are. So the administration might put in some major programs, some of the things that they want in that continuing resolution. But just remember, CRs need 60 votes to pass in the Senate. So let me just conclude by saying this. This room is full of people who've kept communities safer, healthier, and informed, even with one hand tied behind your backs. Imagine what we could do if we actually had funding like it mattered. It's time.
Thank you, Stephanie and Betty Lou. Once again, you have broken this down in a way that we can all understand. Really appreciate it. And of course, you'll be on our future PriorityONE briefings.
We'll
So
see
we
you
look
then.
forward to hearing more from you. Thank you very much. We're going to move to the second part of our PriorityONE briefing now. And I want to welcome to the stage three very special people that we have joining us in person for the PriorityONE briefing. Dr. Stephen Lee, Dr. Kathleen Ethier, and Lance Thoma. And for folks who are on Zoom, we want you to know there's a huge, robust crowd here in the room in Phoenix, Arizona at the what's the name of this resort?
Arizona Grand Resort.
Arizona Grand Resort. Thank you, Steve. That's where we are. And I think our
My
team is
job
going to
here is
post.
done.
Thank you. Our team is going to post a picture. So for those of you on Zoom, you will be able to see what we all look like here, in addition to your Zoom call. So Stephen Lee, as probably most of you know, is the Executive Director of the National Alliance of State AIDS Directors. And we're thrilled you're here with us in person today, Stephen. Kathleen Ethier, you have been with us on PriorityONE briefings in the past. You retired from CDC the Friday before the president took office.
Well timed.
And of course, Dr. Ethier is a longtime director of DASH and a very close partner of ours at NCSD in our field. Thank you for your federal service, and we're thrilled to be continuing our work with you. And Lance Thoma is the CEO of the San Francisco Community Health Center. And Lance, you were our very first guest on our PriorityONE briefing, and so we're just thrilled you're here in person with us to revisit some of that and to also assess where we are today. So let's get started. I'm going to sit down. Okay. So, Kathleen,
You're up.
I'm first.
what is your assessment? This is probably the understatement of the past 4 months. But how would you characterize as how things are functioning inside the federal government right now? And how do you assess the shift in decision making and where decisions get made? Give us your insights.
So I can only speak to mostly to CDC, a little bit to HHS, as you know, I've maintained contact with my former colleagues, and I think there is, you know, when you're receiving emails every day describing you as waste, fraud, and abuse, when you are asked to send emails into the abyss of what did you accomplish last week, when you, when you see your colleagues, the new young staff that you just brought in discarded, there is just a huge sense of, I think, depression is, it is sad, it is traumatizing. So I think people are living in that state of both things happening to them in their work lives that they never imagined. And I'm sure all of you are experiencing that in some form or fashion. But this is happening on kind of this large scale. And thank you all for persevering through that. And that's, I think, the second piece that I would say is that the folks who are still there at CDC and at HHS are doing their very best to persevere. They show up every day. They have to go to the office every day, which is, in many cases, something that hasn't happened. And I think, you know, in some ways, people are happy to be back together and using that sense of community. And on the other hand, everything about their work lives has been oriented around how to make it as difficult as possible. If you weren't included in the reduction in force, everything is oriented around trying to get you to quit, trying to get you to retire early, trying to get you to leave your job. And so that's kind of what the day-to-day is, and that's really difficult. So on just a person-to-person level, it is, you know, when I talk to my former colleagues and friends, I mean, obviously, they are my people, it is really difficult on a day-to-day basis. At the same time, as Betty Lou and Stephanie pointed out, there is no transparency on decision-making about what money goes out the door, where it goes, why it goes. Sometimes money will go out and in other times it won't. Things happen without any kind of transparency of decision-making. So when I hear from when I hear from somebody, now that I'm out, you know, so I'm allowed to talk to you all, and most of my former colleagues are not. And I get asked a question, when I try to go in and find out, get an answer for things, and try to, you know, be a liaison, it's most of the people who are doing the work don't know. In some cases, it's an administrative issue, so the Office of Grant Services is completely overwhelmed because they had to keep doing things in all different ways, and it's just taking some extra time. Or sometimes that gumming up the system is used as a way of not getting money out the door. There are really kind of interesting and new interpretations of contract law and cooperative agreement law and all of those things as a way of not getting money out the door. I think, it's unstated, but I think the goal is to have as much money go back to the Treasury at the end of 25 as is possible. But again, none of that is stated, none of that is transparent. So, and I think decision-making, the third part of your question, the decision-making is incredibly opaque. So at all layers, most people are not being included in the decision-making. Word comes down from on high, and no one knows where that word is coming from. I think that is partly the reason why staff are not allowed to have in-depth conversations with the sites that they support. They're not allowed to come to conferences like this. They are often not allowed to attend meetings. Some of that is loosening up a little bit, particularly with project officers and their projects, but in general, things are being pretty well tamped down. So I talked to some folks before I came, and I think what they would like you to know is thank you for your support. Thank you for continuing to do the work as best you can, and a real sense of loss for them in not being able to have those relationships that they've spent years establishing.
Thank you, Kathleen. And I'm going to come back and ask you a little bit more specifically about what's happened to adolescent sexual health at DASH and CDC. I'll follow up on that in a second. Stephen, boy, you're the man of the hour at the moment because of what's going on with the HIV notices of awards, which, as I know, as of this hour, has still not been issued. Is that correct? Yeah.
That is correct.
So our field has never really experienced this kind of thing before. We've seen this play out in other areas. Delayed notices of awards, clawback of funding, cancellation of grants, cancellation of NIH research grants. Both NASTAD and NCSD have had grants canceled on us for the reason being that there's no federal staff to oversee the projects. Isn't that slightly ironic? But tell us what is going on with the HIV funding as you understand it right now. Just give us a little status report in terms of what we know and what we don't know.
Sure. First of all, good morning. And thank you for inviting me, and thank you for having me. And actually, David, I stood up in the back room when you said, who are you, those of you who are here for the first time. This is actually my first STI Engage, and this is also my first time on PriorityONE. So I'm really appreciative of the opportunity to be here with you all. So what's going on with HIV? I wanted to share maybe three things. And actually, all of the three things I think, David, you just touched on, maybe add a little bit more detail. Specifically, I wanted to talk about the 0047 awards, because I'm sure you're all wondering what the heck is going on with those. I do want to talk a little bit about the RIFs that Kathleen also just mentioned, and I do want to talk a little bit about FY 2026 and what may or may not happen to prevention. So specifically for the 0047 awards, as of what time is it? 10:20 on Tuesday, June 3rd, those awards have not yet been issued. Those NOAAs have not yet been issued. We do know that there are some jurisdictions that have already had to start work orders for partners. Some jurisdictions have been floated additional funding from state dollars or other dollars to continue the work. We don't know at this time when the awards are going to be made, and to be honest, we're still not sure at what level those awards will be funded. We're getting mixed signals in terms of what level those awards will be funded. Not good news, but it is kind of the state of affairs of where we are right now. And to Kathleen's point a minute ago, a lot of that is being determined at a leadership level, and there's a very limited, if no, communication between leadership and the center at CDC. In terms of the RIF, I'm actually going to look at my notes because I do want to make sure I get this correct. I mean, David is absolutely right. Because of the reduction in force at CDC, there have been some awards that essentially will not continue past this year's project year. The ones I want to mention are REACH, the Rural Engagement and Care Using Community Health Workers for Persons with HIV, and those grantees are Indiana, Kansas, Puerto Rico, and South Carolina. The enhanced surveillance of persons with early and late HIV diagnosis to understand system and individual factors associated with new infection and delayed testing. Say that a couple times twice, that's really quite a mouthful. And those grantees were Florida, Houston, Louisiana, and Michigan. And then the third one I want to mention is Together Take Me Home, which is, it's still going through September, is a project that funds home HIV and syphilis and STI testing. Those awards have been informed, or those grantees have been informed that those projects will not continue beyond this current project year. We don't know what's going on with MMP at the moment, the Medical Monitoring Report. We haven't gotten confirmation at this point. But if you read the tea leaves, the project officers and staff who staff the MMP at DHB have been RIFed. And so if you follow what I just said, it's probable that the MMP may not continue as well. And then the third bucket that I wanted to talk about is FY 26 and prevention. And I did notice I don't know if I think it was Betty Lou who did a kind of a synopsis of the FY 26 budget. I think one thing that was not included, or it wasn't obvious, is that the present budget proposes to eliminate DHP and HIV prevention funding, which is $790 million of funding.
And 790 million of funding. I need to hold this.
Yeah, and so I'd love to, during the course of the conversation, I'd love for us to talk about, okay, so what the heck are we going to do about that?
Thank you, Stephen. Yeah, and I was just going to say, I'm going to come back and ask you that question. What can we do about this? Boy, that's the question of the moment. Lance, I just have to say those are the most fabulous eyeglasses I've ever seen.
Thank you.
Look great.
Back at you.
Socks. Stephen, your shoes. Kathleen, hey, we're a good-looking crew up here today, if I may say so myself. Lance, Lance, on a very serious note, specific communities are being targeted in this environment. There is, I mean, I can scarcely utter the words, this almost unspeakable, bold attempt to erase trans people from American society and culture, people of color. And this administration has used a variety of tactics and moves to, put it mildly, hurt these communities. What mechanisms have you seen being employed for the people that you serve, and how is the San Francisco Community Health Center coping with that?
Ooh, yeah, thanks, David. And
I know it's a very big question.
Good to be with all of you, and thank you for inviting me to this panel and to talk about something that is so horrible that's going on. You know, I think when the executive orders were issued, the onslaught of them, of course, the gender ideology executive order was shocking, to say the least, when I read it. It chilled me to my bones to see that a whole group of people could be erased, disposed of. It read like that. And just to share, at San Francisco Community Health Center, we're a people of color and LGBTQ health center, and much of our work is centered around trans communities. A quarter of our patients are trans or gender nonconforming. We have an emergency shelter in San Francisco specifically for the community. We have a community resource and drop-in center, standalone facility for the community. And so this executive order just it made me beyond frightened for my team. And we have nearly 200 staff, 50% of them, so 100 staff members are trans or gender nonconforming in my organization. And so to think that this is the message and this is what's happening at the federal level, it was horrific. And so I think then what we saw is that our federal funding was directly targeted within a week of that executive order being issued. And I just want to thank, David, you put out a call to many of us about whose awards are getting targeted, and I was on the phone immediately because that our notice of award was terminated outright on February 1st. What we have done since is what I will say, which we have never done before, is we took part in a lawsuit against the Trump administration. And so it is a part of our work and advocacy, the judicial branch, that is the most unfamiliar to me, but it has become, I have become so schooled on it. There are 9 organizations, LGBTQ organizations across the country, that are part of this lawsuit, and we're being represented by Lambda Legal. And I just would say that, so that the judicial system has to be our hope in many ways in terms of how we fight back. And yet, it doesn't provide all the cover, right? In the trenches, what we're seeing is that things are just getting chipped away. And I think that's what we'll talk about more. When I just think about what Stephen, what you were saying, the CDC, I will say, my organization started as an Asian and Pacific Islander HIV organization, and the only way we started and survived from the 80s, 90s, and beyond was because we worked with the CDC to understand the data in API and Native communities around HIV and STIs, and then lifted that up so that organizations like mine could actually get funding. And to think that everything that, it just breaks my heart, everything that you said is going to stop right now, because it is about how do we identify where are communities of color, where are trans communities, where are low-income communities who are not getting treatment, who are not getting access to resources, not even being identified in terms of having whatever disease and health condition they have. This is what the CDC has been doing. This is why CDC worked with communities like mine and partnerships that we established that it's just heartbreaking because those relationships have been severed.
Lance, thank you. What I want people to understand is that, very early after the swearing in, there was such uncertainty, but there is something called the FAP listserv in Washington. And Lance and I became fast friends on the FAP listserv. And because you were posting information, and then I asked for follow-up information, and some of those interactions are what led to the idea of creating PriorityONE, by the way, because we realized that in this environment, this has really pushed, in a good way, this has pushed us at the national level to think very hard about doing our work differently and faster. The speed of which developments have happened has been very, very hard to stay on top of. People have thought through a strategy here, and they are winning. And they are a couple of steps ahead of those of us who are trying to catch up and understand what these changes mean. So Lance, your work is so important, and your communication and the information you posted on that listserv and in so many other ways, you've contributed to the national response. And I think we all really appreciate that. So moving on with some questions. So let's say, I guess we're moving into a discussion of kind of scenarios now. Some of this has happened, some of it hasn't happened yet. But what happens in your view, Stephen, I'm going to start with you, if we end up with a series, and for those of you following on these questions, I'm skipping ahead a little bit, because I've been told via our Slack channel that I am behind schedule. Surprise, surprise. Yes, that's my story. Anyway, Stephen, what happens if we face a series of continuing resolutions, in your view? What does that do to the whole system?
Sure, where's Betty Lou? So first of all, I think we need to understand what a continuing resolution is and how they're structured, right? And so there's and when Betty Lou comes back, I'm sure she'll correct me on this, but there's a continuing resolution that says we will continue to fund the federal government at the level of the previous year without any changes to the budget numbers and or changes to the budget language. And then there are continuing resolutions that basically gives the president a blank check, and does not necessarily refer specifically to the previous budget and or makes adjustments. And I think the concern is which one of those happens if we have a continuing resolution in going forward. If there's a continuing resolution with a blank check, I think woe is us, because I think all of the things that the administration would like to do and maybe are restricted or restrained because of oversight or congressional oversight would go away. The continuing resolution is a process that allows the Congress to provide oversight of the budget and the way the money are spent, and taxpayers' dollars are spent. And so depending on the scenario, I think things could actually get worse, to be honest.
Right, because we could see the continuation of Congress ceding its power of the purse to the executive branch, meaning that they would continue to make whatever decisions they want about how the money is allocated. Thank you, Stephen.
And decide which programs they want to fund and which programs they don't want to fund.
That's right. We're going to come back to this a little bit when we bring our other panelists back. But continuing on this theme in terms of scenarios, Kathleen and Lance. Kathleen specifically, what is going on with adolescent sexual health now in the US? And are there opportunities under this kind of scenario to shift any of this to the private sector? And then Lance, I'm going to follow up with you with a very similar question.
So in terms of what's happening right now from CDC's perspective, the Youth Risk Behavior Survey, which is one of kind of the DASH's main contributions to the field, is currently in the field. It is ongoing and running, I think, relatively smoothly. I was very concerned at the kind of beginning of the new administration. The division was told they had to go in and take the transgender identity question out of the national survey, so we won't have that data for 2025. So that is very concerning. On the other hand, we will have data. I think as long as we're on a continuing resolution and the structure of CDC stays somewhat the same, that data will be collected. The What Works in Schools program, which is kind of the primary way that CDC works on adolescent sexual and reproductive health in the field through schools, that continuation is due August 1st, and they were told to ask, I'm still having trouble with the we versus they now, but they were asked to get continuation applications, so that seems to be moving forward, but I think, to your point, at the very end, it's not clear whether money goes out the door. That money is all HIV, those are all HIV dollars. So if there is a general restriction on putting HIV dollars out into the world, it's not clear what happens there. So there's work that is still uncertain. Some of the core work is still moving on. I think if we have to envision a world in which CDC's HIV prevention is eliminated and the chronic disease prevention, which is the other kind of contributor to DASH's work, that also is being slated for elimination. If that happens, at that point, and then also I do want to mention that in the 2026 budget, the Office of Population Affairs, which is where the teen pregnancy prevention program sits, as well as the Title X family planning program sits, those are also slated for elimination. That is a huge, enormous way in which adolescents receive their reproductive and sexual health care around the country. If those programs are all decimated, I think we're looking at kind of a state-by-state approach to sexual health, not just for adolescents, but for everyone, that is going to require a public-private partnership that exists in some forms in some ways, but is not, I think, fully engaged at this point. And I think the work for all of us at this point who are outside the federal government, who are trying to figure out how to get prevention and services to all people, but including young people, including trans people, I think we have to go into some serious planning and development mode to figure out how to create those systems on a state basis or a regional basis.
In order to avoid vast differences based on geography and state, right, Kathleen?
Right, I mean, I think that's where, I think you end up exacerbating already existing disparities with that approach. I mean, that's why federal leadership is so important. But in the absence, I think currently we are devoid of federal leadership in general, so it's not too soon to do that planning. But I think at a kind of national org level, what we can then provide is at least guidance and support. Resources are going to vary from region and from state to state, but I think in terms of guidance and support, that's what we can provide.
Yeah, thank you, Kathleen. Lance, you are in the state of California, of course, a progressive community of San Francisco. You head a community health center. Assuming this scenario of vastly changed federal resources that directly impact your organization, what is your own thinking about the future? Can California make up for all of this? I know California has a $19 billion deficit right now. I only know that because I recently gave a speech in California. But that's a shocking amount of money right there. But what is the thinking of you and your team and your organization and your board about how you're going to move forward in a scenario that is more along the lines of vast changes and vast funding cuts?
Yeah, and I am in California, I am in San Francisco. I think even as much as we are a target because of the undocumented community, because of trans folks, for so many reasons, it's also why I felt like I could be in a lawsuit against the Trump administration, and I don't take that for granted. And at the same time, our state has a multi-billion-dollar deficit. There are queer health programs. We are in Sacramento right now advocating for programs that have been cut out of the governor's budget. In our current city, we have also near $1 billion deficit. So we're engaged in that. I think ultimately there is just less all around. And as that happens, and of course the Medicaid cuts, how it gets to California, the amount, the level and scale of what the federal funds provide to California for our Medi-Cal program, I can't imagine how we could cover any of that. What we are doing our best to do is trying to ensure that the most vulnerable folks continue to get health care. For us right now, we're focused on, of course, undocumented communities in California, but very squarely for me and many of my partners, it's around transgender care, it's gender affirming care. What we know, even with these notice of awards, they could come out, and what we're seeing is there are conditions on those notice of awards. We're seeing them, that you can't provide any gender affirming care, or they put these conditions where you have to carve it out. And we're doing our best to work with our city health department and our city leadership to come up with these worst case scenarios. And I do think, at least in San Francisco, we have a strong HIV/AIDS providers network for years and years, and I co-chair that network. So I work directly with the leadership at the Department of Public Health and all of our elected officials so that we raise this up, so that we can figure out how we then continue on to provide care in some form or fashion. And it's going to take everyone, it's going to take all of these foundations, all kinds of monies and funds to ensure that we can do that.
One of the things to keep in mind that I think we haven't fully grappled with yet is that the administration, in addition to talking about waste, fraud, and abuse, is talking a lot about sending activities back to the states.
Right.
But they're not sending money back to the states, except in a couple of greatly reduced block grants. And if that goes through, it's not just about HIV, STI, reproductive health dollars. It's also about FEMA dollars that are not going to states. It's also about transportation dollars that are not going to states. And so state budgets are not only going to have to figure out how to do with less Medicaid, how to do with what to do with less for health departments. They're going to be also making up budgets around their disaster preparedness and response, their transportation dollar, all of the other dollars that go to states from the federal government. The states are going to have to be making that up. Tax revenue, people are not going to be paying less money in taxes, so money is going to be going to the federal government, and it's not going to be coming back to the states in the same way that it is. And in many cases, that also means southern states who get the bulk of that money, rural states who get the bulk of that money, are going to be dealing with less federal revenue. So also then asking them to support healthcare in the way that they're going to need to is going to be devastating for many states. And so I think we have to grapple with that whole piece, not just the piece that affects the work that's important to us.
It's a fundamental realignment between the federal government, state government, revenues from taxes, and so forth. And I think it is so basic and fundamental to everything we have known in our lifetime. That is what we have to be prepared for in the future. Chris Zivelich has some fantastic questions coming in from our Zoom audience. I'm going to bring him back in 1 second. But Lance, first Priority One call, you gave a very moving account of what you were doing to help take care of your trans staff. And I want to ask you that question once again. What are you doing? How has it evolved over the last 2 months? And what can people learn from your experience? What would you advise people?
I think what I shared was that even being a part, however we fight back, our staff care and are looking for leadership because it's not out there in our country right now. And so not only the lawsuit, but the lawsuit was tremendously morale boosting for our trans staff because it felt like, wow, there is a way that we can push back against this horrific kinds of threats to our existence. So I would say that, but I will also say in the day-to-day, as my trans team members are taking care of the community and they're just terrified to get services. They're feeling isolated, the mental health issues are just off the charts. And then our staff who are trans themselves having to take care of their communities. What we're doing, we're really trying to leverage our behavioral health team members to actually support our staff. So we're creating staff impact groups that happen pretty regularly so that our behavioral health teams are there to provide support to our staff members who are traumatized themselves. And it's not just our trans staff. We hire folks with lived experience of homelessness, of substance use. And so all of these are such triggers. These are the communities that are actually on the chopping block when we're looking at Medicaid issues, Medi-Cal for us, any of these HIV resources, all of that. So it's been a huge lift, but I also feel like it's what we need to do in these times.
Absolutely. I think there's a lot more we could get into that. But I'm reminded of my own social work background, which is taking care of the helpers in order for the helpers to be able to take care of others is a very important body of work and lessons learned that we all need to take stock of. And everybody in this audience today and on Zoom is in the same position. You are helpers in different roles, but you have to take care of yourself in order to take care of others. Chris Zivelich, let's bring you back on stage, and we're going to move to questions coming in from across the U.S. in real time. Did Chris disappear? And we're bringing back Betty Lou Taylor and Stephanie Arnold Pang. Thank you for rejoining us. You look refreshed since your last grilling. Chris, take it away.
Yes, thank you. I'm not dropping my notebook. See, I learned my lesson. Okay, we had a lot of really great questions coming in on both our Zoom chat and the Q&A app. So first of all, thank you all for submitting those questions. Stephen, we have a really interesting question for you that actually also relates to the jurisdiction we're in, because some states are not EHE jurisdictions, or only part of them are, like here in Arizona, where it's just Maricopa County that's an EHE jurisdiction. So, what are some of the implications of cutting HIV prevention money for jurisdictions that are not EHE priority jurisdictions?
Yeah, actually, that's a really, really good question. And actually, I had a bullet point in my notes here that had a big question mark, because it's a good question, right? As Betty Lou's slide pointed out, EHE from CDC, 220 million, I think you said, was moving over to AHA. The 157 and then 165 was continuing for EHE, but EHE specifically is in 57 jurisdictions. And so for the jurisdictions that are not funded through prevention work that is not funded through EHE, there's a big question mark of what then happens with those jurisdictions. I got a question yesterday. I think there's a lot to unpack in terms of what moving these resources mean. These EHE dollars currently housed at CDC are the grant mechanisms with CDC moving with it to AHA or not. And so how are those grant mechanisms going to be implemented for those jurisdictions that actually have EHE funding as well. So there are a lot of unanswered questions at this time in terms of implications. I think to the conversation we just had around funding, we really, really have to stop this. We can, it just doesn't make sense to me that we could have in the United States no HIV prevention program. And so what are the efforts that we need to really be doing is the advocacy, the education, the work with our local and national leaders to ensure that this does not become a reality. I think one of the key things that Betty Lou really shared that resonated with me is that this is a proposal. This is not final. And so what do we do between now and we get to a final to prevent this from being the reality?
Great, thank you, Stephen. Speaking of Betty Lou, you mentioned her a couple of times, and we have a question for Betty Lou. And this one came in from our Zoom audience. So I want to, again, thank our hundreds of people on the Zoom audience watching right now. What is the status of creating AHA by eliminating or consolidating multiple agencies? So what is the likelihood that Congress can and will actually stop that process from happening?
So this is a new proposal to create the Administration on a Healthy America. That takes a lot of legislative language. So this proposal will now go to the authorizing committees, which actually writes that legislation. The House will have to write a bill, the Senate will have to write a bill, and then they will have to consolidate and conference those two House and Senate language. So this is going to take a while. I mean, you can't move programs into a piece of legislation or into a new administration that's not there. It hasn't been created yet. So this is going to take a while.
Great, thank you. And we also have a question that we're going to actually do what is always fun in one of these panels and go down the line. So everybody has a chance to answer. And some of you kind of alluded to this a little bit in your responses, so feel free to elaborate on that. But what do you see overall as opportunities within this chaos? There's a lot of chaos happening, but it's also an opportunity for opportunities, and what are the ones that you're looking at or prioritizing or thinking about? So we'll start with Stephanie.
Ooh, we're starting with me.
Ooh, there you are.
All right, so hopefully this is not a $2 trillion question like the last one I had to think about. We spent a lot of time yesterday as the NCSD staff with the NCSD members, so thank you all for that time. But what I want to say is that, as David already mentioned, STI funding will continue, and so I'm thinking really speaking from an NCSD STI perspective. I want folks to be thinking about what is your core? What's your core? What are you going to, and what do you need to keep doing? And I think Kathleen mentioned this when she was on our PriorityONE briefings earlier this year. Think about your need to have, want to have, it'd be nice to have, and how are you going to maintain that? And think about what are the opportunities to what are you going to stop doing, and what are you going to continue to do? Because particularly if we're thinking about consolidated appropriations, it may not happen this year. It is only a proposal, but it's something that's out there in the ether and may continue to come up. So take this time while we're in a proposal to think about what are the opportunities, if you're starting from scratch and you're not being told from your funder what to do, what are you going to choose to do to meet the needs of the programs and the people you serve?
So, yes, there's much chaos, but again, these are just proposals. You need to contact your congressman. You need to contact all your local officials, your state and local officials, and your federal officials to tell them what the impact of this is going to be on you and your community. I mean, you know, all of these cuts, consolidating these programs, this is going to take quite a while, but you know, you need to let them know that this is going to have a major impact on your work and your community and the people that you serve.
Since Stephanie already said the thing I have said before, it's great. I think that there is great opportunity in the coming together. I have some friends who are Canadian, and I said, you know, how are things in Canada? And they said, we are prouder and more cohesive as a nation than we have ever been. And I think some of that applies to our public health communities. I think we are, and I hope you all are understanding the value of federal employees and your colleagues at the federal level. I think we are valuing these opportunities to come together. I think we're valuing the opportunity to have these conversations. And I think it's allowing us to say, okay, that was what we had. Now, what do we really need? And how do we grow that? And how do we kind of envision that into being? And then how do we figure out how to resource it? And so from a really optimistic standpoint, sometimes when you burn things down, really wonderful things grow from that. And so I hope we can continue to take the opportunity to work on that.
I'm thinking about what, David, you opened with, the past is prologue. You know, when I think about where I go, is that we have been here before as an HIV community. We didn't have anything, right? The federal government did not pay any attention to HIV in the 80s. And it took community to rise up, to push our elected officials, but to push government to take care of us. And I think that is where I go to in this moment. It's like, actually, what do we need to do to sound the alarm as a community? Because our lives are at risk, our communities' lives are at risk, and so the other thing I will say to that is we can't afford to be isolated. In times of stress and fear and terror, especially community-based organizations, I see this, I've seen it for so long. You go inward. Like, what do I do now as an organization? Because all of us, you know, my funding is threatened, or the board is, you know, we have to look up and look out and actually start planning, strategizing together with other organizations, other communities, push our national organizations to ensure that you are looking out for us, carrying our messages to DC. We'll do the work in our districts, but it's about that, it's that connection. We gotta fight. So that's the opportunity.
So I think I will just ring the bell and all the things that you all just said, but maybe stating it in a different way, which is I really see the opportunity as creating these multi-sectoral coalitions for a movement. If you take a big picture step back and think about, especially in the HIV field, what's being attacked. HIV prevention at CDC, research at NIH, housing ad hoc through HAPWA, Medicaid cuts. 40% of people with HIV receive their care through Medicaid, and so any discussion around Medicaid cuts will impact HIV folks very directly. And so a 5,000-foot view or 10,000-foot view, we really have to come together as a multi-sectoral movement to try to move the needle on this. And it's, that's, you know, so one thing we learned from the Tennessee experience of a year ago, where both national and local organizations really coalesced, that's an opportunity for us.
Awesome. Well, thank you all for those answers. That is unfortunately all the time we have for the Q&A on my end. I believe I'm going to pass it back over to David for some housekeeping notes, so thank you all.
Can you hear me? Yes. Panel members, thank you all very much. This was such a meaningful, moving discussion. We could continue all day, and I wish we had that time. But there is going to be the opportunity for us to talk more with all of you informally as the days ahead play out for our conference. I hope you'll take that opportunity. I want to thank you from the bottom of my heart for being here in Phoenix. Thank you all, and thank you most importantly for the national leadership work that you do. It makes such a difference. So everyone, a huge round of applause.